السلام عليكم. المرحلة الرابعة. الحمد لله على سلامتكم وعلى سلامة عوائلكم، والله يحفظ أهل البصرة والعراق والبشرية أجمعين، والله إن شاء الله ينصرنا من هاي الغمة ويحفظ جميع البشر يا الله، بالتوفيق للجميع إن شاء الله. Today we are going to discuss a very important subject, which is the hypertensive disorder in a pregnancy, because they found that hypertensive diseases in a pregnancy is a major killing factor, and it is a major cause of maternal mortality all over the world. Hypertensive diseases associated with the pregnancy can be divided into 5 major categories. Number 1, chronic hypertension. Number 2, gestational hypertension, preeclampsia, eclampsia, and HELLP syndrome. What we mean by chronic hypertension? That means the patient got a pregnancy while she's already hypertensive. She got an elevated blood pressure equal to or more than 140/90 millimeter of mercury before 20 weeks of gestation, or there is a persistence of hypertension beyond 12 weeks after the delivery. That means the hypertension doesn't disappear after the delivery of the patient. While what we mean by gestational hypertension, that means and a blood pressure equal to or more than 140/90 millimeter of mercury on 2 occasions, 4 to 6 hours apart in a previously normotensive patient. Usually occurs after the 20 weeks of gestation, doesn't associate with the proteinuria, and it returned to normal after 12 weeks after the delivery. Almost half of these patients develops preeclampsia syndrome. There is a category that composed of preeclampsia superimposed on chronic hypertension. That means the hypertensive woman, she gets pregnant and she develops pre-E with chronic hypertension, in which there is a new onset of proteinuria more than or equal to 300 milligrams per 24 hours in already hypertensive women, but there is no proteinuria before 20 weeks of gestation. She develops a sudden increase in proteinuria or blood pressure or platelets count less than 10,000 per cubic millimeter in a woman with hypertension and proteinuria before 20 weeks of gestation. Those carry a more adverse outcome to the fetus as well to the mother than preeclampsia alone. Preeclampsia means a new onset of hypertension and proteinuria in a previously normotensive woman. Usually occurs after 20 weeks of gestation, returning to normal after 12 weeks of pregnancy. Oedema is not a part of the diagnosis now. Patient, if it's not getting well, she might develop a very severe condition which is called eclampsia. It is a new onset of seizure or epileptic fit or unexplained coma during a pregnancy or postpartum period in a patient with a pre-existing eclampsia and without a pre-existing neurological disorder. يعني البيشنت رأسا she developed an eclamptic fit without any history of CNS disorder or epilepsy, and she got only pregnancy with PE. There are risk factors of preeclampsia, mostly preconceptually related to the partner, such as nulliparity and limited exposure to the paternal sperm, while those which are not related to the partner, such as the family history of preeclampsia and history of preeclampsia in a previous pregnancy. Advanced maternal age. It's a history in the previous pregnancy with abruptio placentae, intrauterine growth restriction, fetal death. Even it's very common in non-Hispanic black race. Other risk factors for the development of preeclampsia consist of maternal factors related to the mother. Obesity found it is a risk factor. When her body mass index is more than 35, it will double the risk of the development of the hypertensive disorder and preeclampsia. Patient with history of hypertension, patient with diabetes, or thrombotic vascular diseases. There is certain behavioral risk factors such as smoking. They found it to prevent the occurrence of PE. But once a pregnant smoker woman develop PE, usually it carries a bad prognosis to the mother as well as to the fetus. What is the pathogenesis behind the occurrence of PE? The exact mechanism of the occurrence of PE is still unknown, but there is certain theories that might explain this disorder, such as abnormal placentation, or there is an inflammatory mediator imbalance, where there is a decrease in the prostacyclin and increase in the thromboxane A2, which lead to a vasoconstriction, increase in the platelet aggregation, increase in the vasopressor response, and increase in the uterine activities. As we see in this slide, this is in non-pregnant women in which there is a narrowing in the spiral arteriole. This is in a normal, there is a dilation of the spiral arteriole, while in a PE, there is a narrowing in the residual myomaterial portion. The third theory, they say there is a genetic rule in which there is a family history of a preeclampsia, and there is a genetic origin mutation in complement regulatory protein gene. That means there is a gene association. And there is also an immunological theory. There is a defect in the immune system. واللي يأكد على هذه النظرية إنه they found that exposure to sperm of different partners reduce the risk of PE, while long-term exposure to the paternal antigen in sperm of the same partner get a protective mechanism. And they found that activated autoantibodies to angiotensin receptors, EZAID receptors, and increase the sensitivity to angiotensin, which lead to the hypertension. There is certain risk factors on the fetus as well or on the mother. On the fetus, increase the risk of intrauterine growth restriction, severe oligohydramnios, placental infarcts, placental abruptio, prematurity, uteroplacental insufficiency, perinatal death, while those on the mother, CNS disorders lead to a seizure and stroke, disseminated intravascular coagulation, increase the risk of operative delivery and cesarean section, renal failure, hepatic failure or even rupture, and sometimes even maternal death. What are the hematological changes? There is heme concentration. The platelets with anemia may appear to have normal hematocrits. Sometimes severe thrombocytopenia, and it is so common. Platelets counts correlate with the disease severity and an incidence of abruptio placentae, DIC, due to the activation of coagulation cascades, which lead to the overconsumption of coagulants and the platelets, leading to severe spontaneous hemorrhage. What are the effects on the liver? Patient might with severe PE or preeclampsia or hypertensive disorder might develop a HELLP syndrome or periorbital hemorrhage or subcapsular bleeding and hepatic rupture, in which 32% might cause a maternal death. While the effect on the kidney, there is a decrease in the glomerular filtration rate, which leads to severe oliguria or renal failure, elevated uric acid, creatinine being elevated, a glomerulopathy, and proteinuria. What is the effect on the placenta? There is a uteroplacental circulation disorder here, in which there is a uteroplacental insufficiency, which lead to a fetal complication such as hypoxia, intrauterine growth retardation, prematurity, abruptio placentae, and intrauterine death. What is the most important symptoms and signs of PE? There will be edema of the face and the hands, that means edema in the independent parts of the body. Sometimes they develop a generalized edema known as anasarca, headache, visual disturbances, blurring of vision, diplopia, epigastric pain, elevation in the blood pressure, exaggerated reflexes with proteinuria. What are the prevention methods? We can prevent PE and its complication by regular antenatal checkup. We check which is the high risk group, which is prone to develop PE, should be regarded as a high risk pregnancy, and they need a regular and frequent antenatal checkup, such as patient with rapid gain in weight, patient with rising blood pressure, those who develop edema during pregnancy, or those who got proteinuria and rearranged liver or renal profile. We can give them a low dose aspirin, 81 milligram, in this high risk group, in which we restore the balance between prostaglandin and the thromboxane A2. Calcium supplementation to effect. No effect is so clear unless women are calcium deficient. Sometimes we give antioxidants such as vitamin C and E, in nutritional supplements such as zinc, magnesium, fish oil, low salt diet. How we treat a patient with gestational hypertension while she is at term. Delivery is always a reasonable option if term. Why we are keeping the fetus in a patient who is hypertensive nearing term? If the cervix is unfavorable and maternal disease is mild, we can allow them for expectant management until they pass into a spontaneous labor with the close observation is a possible option. While if she's got mild hypertension but not at term, rule out severe disease should be excluded. Conservative management and close observation to the general condition of the mother as well as of the fetus. Serial laboratory tests, twice weekly antenatal visits, antenatal fetal surveillance and fetal well-being assessments, and we should decide whether she needs an outpatient versus inpatient management. The indication for termination of pregnancy and delivery: when there is worsening of the blood pressure in spite of treatment, non-reassuring fetal condition and sign of the fetal distress start to appear, development of severe pregnancy-induced hypertension, when the lungs get mature and no need to keep the fetus in utero anymore, and when there is a favorable cervix, and we can induce such a patient. While those patients with unfavorable cervix, if there is no contraindication to prostaglandin agents, we can right the cervix and we can induce them, and induction of labor can be performed. If the patient is less than 30 weeks and the baby is so small, or the fetus is so small, and he cannot tolerate induction of labor, consider the cesarean section. When the cervix is favorable and the size of the baby is good, we can allow oxytocin and we can deliver them vaginally. Preeclampsia, PE, which is a very important branch of the hypertensive disorder in a pregnancy. What is the obstetric management of the preeclampsia? First, we need to do a maternal evaluation. We check the hemoglobin of the mother as well as the hematocrit. We check the platelets count. If it's decreased less than 10,000, لازم أحتاج أسوي وياها coagulation profile and restore any bleeding tendency. We should check the liver function test in all these patients and renal function test, in which we saw there is increase in the urea as well as in the creatinine, and it decreased in normal pregnancy. Routine urine examination, we found that they got an proteinuria. What are our main objectives in the management of the preeclampsia? Termination of pregnancy with the least possible trauma to the mother as well as to the fetus. Birth of an infant who subsequently thrives. Complete restoration of the health of the mother after the delivery. Which one need hospitalization? Those with a new onset blood pressure more than 140/90 millimeter of mercury. Those with worsening blood pressure in spite of treatment. Those who develop proteinuria in addition to existing elevated blood pressure. What is our main strategy, or our main goals, or our main plans in the management of patients with severe PE? Number one, we should start with anticonvulsant therapy. We should stop any fit, because with each fit, millions of brain tissue will die and they will never get healthy again, or they regenerate again. So first we should stop a fit, then after we should lower the blood pressure, and lastly we should remove the cause of this pathology by termination of pregnancy. This is the main goal in the management of severe PE. What are the anticonvulsant therapy? How we prevent seizures, especially اللي هما seizure prophylaxis, routinely used in severe PE to prevent the occurrence of a fit. هو magnesium sulfate is most commonly used, initiated with the onset of labor till 24-hour postpartumly. هذول اللي يجيبون normal vaginal delivery. But those who are going to subject it for cesarean section, we should start on magnesium sulfate infusion 2 hours before the operation and keep them 12 hours on the infusion in the postpartum period. What is the side effect of magnesium sulfate? It has a side effects on the mother as well as on the fetus. On the mother, there is a flushing of the face, severe headache, severe muscle weakness, pulmonary edema, decrease in the patellar reflexes, respiratory depression, and cardiac arrest. While on the fetus, it causes lethargy, hypotonia, respiratory depression. They found this is a very dangerous drug because its therapeutic index is very close to its toxic index. So we should give it in infusion with the close monitoring to the mother as well as to the fetus. How we monitor the magnesium level? Its normal serum level usually 1.7 to 0.4 milligram per dl. Its therapeutic range نقبل B when its serum level reaches 5 to 9 milligram per dl. Paternal reflexes will be lost when it's more than 12, while there is a respiratory depression when serum level reaches between 15 ila 20 milligram per dl, and they are going to develop a cardiac arrest when the level is more than 25 milligram per dl. How we treat the magnesium toxicity? By stopping the infusion immediately, we give intravenous calcium 10 millimeter of a concentration of 10% over 10 minutes, and we treat the respiratory arrest by endotracheal intubation in case of respiratory depression. What is the antihypertensive therapy? In patients with mild PE, there is no benefit of antihypertensive therapy, just reduction in the maternal blood pressure with labetalol or nifadipine, but it might cause intrauterine growth restriction, while the acetylcholine inhibitors are contraindicated in pregnancy. They will cause intrauterine growth restriction, bony malformations, limb deformities, pulmonary hypoplasia, RDS, severe hypotension, and death to the fetus. While in severe PE, the antihypertensive therapy is used to control the blood pressure until the patient delivers, or in a preterm, we should at least inhibit delivery for 48 hours to allow time for glucocorticoids administration in order to enhance the fetal lung maturity. Then we deliver the patients. While those with severe elevation in the blood pressure, they are in acute medical illnesses, they need either we prescribe for them hydralazine 5 to 10 milligram every 20 minutes, or labetalol 20, then we increase it to 40, then 80 every 20 minutes until we reach a maximum dose of 220 milligram. Nifadipine 10 milligram per oral, not sublingual. Nitroprusside, diazoxide, and clonidine 1 milligram per oral. While those who develop a HELLP syndrome, what is an HELLP syndrome? It is an hepatic enzyme elevation and low platelet syndrome. Diagnosis through hemolysis. The patient develops hemolysis, by which we check the peripheral smear. Bilirubin is increased more than 1.2 milligram per dl. There is elevation in the liver enzymes, the SGO2, GAO2, and the SGPT, and the alkaline phosphatase, and patient develops a low platelet count. The management of HELLP syndrome. Immediate hospitalization. We should stabilize the general condition of the mother by using anticonvulsant agent number 1, 2 antihypertensive agents, correct the coagulation abnormalities. We should assess the fetal condition by fetal heart monitoring by Doppler ultrasound, and we check the biophysical profile of the fetus and whether she develops any fetal distress or not. In a HELLP syndrome, our ultimate goal, when she is more than 34 weeks of gestation, we should deliver her. When she is less than 34, we can allow her to pass into expected management, but she needs a very close observation, the mother as well as the fetus. If she's a stable mother and the fetal condition is good, we can allow her to pass into expectant. But we should check the platelets count. She needs a platelets transfusion if it's less than 40,000 before cesarean or less than 20,000 before normal vaginal delivery. We should think in patients with severe hypertensive disorder, that means severe PE, eclampsia, or HELLP syndrome, termination of a pregnancy. So what are the indication of termination of a pregnancy? When the patient is term pregnancy with mild or severe PE. Patient with severe PE regardless of her gestational age, the fetus. شنو هي الورنينج ساين اللي تقول لي patient develops severe PE؟ She develops headache, visual disturbances, epigastric pain, oliguria, or patient develop eclampsia. Patient must be stabilize her blood pressure, prevent a fit, then deliver her immediately. If she's preterm with mild PE, assess the fetal well-being by non-stress test and by a Doppler ultrasound. The method of termination, we should think by first vaginal delivery, never think by cesarean section. So our goal to deliver them vaginally. So we should think about induction of labor with the prostaglandins in order to ripe the cervix, then we followed by intravenous oxytocin. Elective cesarean section done in a patient with severe PE and she got unfavorable cervix. Eclampsia or eclamptic fit. Its epidemiology is around 0.5 to 5.5 per 10,000 pregnancies, decreasing in incidence with time. Antepartumly occur in 50%, intrapartumly in the 30%, postpartumly in 20%. Usually it's occur within the first 48 hours after the delivery. First beyond 7 days generally rules out eclampsia, and it got a very bad prognosis when eclamptic fits occurs after the delivery. What are the risk factors for development of eclampsia? When the maternal age less than 20 years, she is multicravita with molar pregnancy or triploidy, or there is a pre-existing hypertension or renal disease, she got a previous severe preeclampsia or eclampsia, when she got a non-immune hydrops fetalis, when there is a systemic lupus erythematosus. These are the risk factors for the development of eclamptic fit. What are the clinical picture of the eclamptic fit? There is an eclamptic convulsion such as epileptic form and consists of 4 stages. Stage number 1, which is called a premonitory stage, in which there is twitching of the muscle of the face and tongue, lip and eyes, eyeball were ruled and turned to one side. It lasted for 30 seconds. Once it ends, it will start a tonic stage, in which the limb gets flexed, hand getting clenched, also lasted for 30 seconds. The third stage, تنكت تبدي المريضة هنا, lasted for 1 to 4 minutes, in which there is a frothing and tongue is bite and there is a shallow breathing. While stage 4, it's got a variable period extended from few hours till few days. How we manage a patient with eclamptic fit? First, call for help, because it is a very life-threatening condition, so the most senior obstetrician should be available with you. Put the patient in a left lateral position, remove the clothes and protect the tongue, put an artificial airway, blood pressure should be checked for basal investigation, Foley catheter to assess the renal function, magnesium sulfate to lower the blood pressure and prevent a fit. If it doesn't stop, use a diazepam, 10 milligrams slowly and diluted, which can be repeated after 10 minutes using antihypertensive therapy and obstetrical examination to decide the mode of delivery. Then deliver the patient and think about vaginal delivery first before you think about the cesarean section.